So good morning, everyone. Thanks for coming so early, and thanks, Kevin and Molly, for the invitation. So, well, whoops. Oh, okay. So, the outline of the presentation is gonna be that we will go through the basis of both fMRI from a point of view of data analysis. Then I will introduce the sources of the fMRI signal, and then we will discuss like methods to correct for those artifacts and noise components that are in the fMRI signal, using nuisance regression, using independent component analysis, methods based on principal component analysis, methods that use multi-echo fMRI acquisitions, using the phase, and I could probably also cover global signal regression, but we are going to skip that part in this talk. So let's start with the basics of both fMRI data analysis. So as you know, in fMRI, what we do is we collect two star weighted images while we are doing an experimental paradigm. And what we have is a series of time points that measure like differences in the concentration of oxygen in blood that they respond in response to the task. So what in order to analyze that, what we do is we define a regressor based, we hypothesize the hemodynamic changes that should follow, that we could have considering the timings and the durations of our events, and then we fit that regressor to the signal in all the boxes in the brain so that we have we can estimate the amplitude of the response to that particular regressor. We could also add nuisance regressor that trying to explain other fluctuations that are in the signal, and we actually fit the entire model to the signal, and the fitted signal is the red curve that you see that. And you fit that to all the voxels in the brain, and then you get this map. It turns out that we see the time series in the time domain, but if our sampling rate is really fast, like in this case that we have about 300 milliseconds, we can see that the frequency response of the task-related component, it only occupies the low frequency of the spectrum. But we also see some peaks that, what are they? Those are components in the signal that are present there, but are hidden in the response. So depending on where you go, in which voxel you take, you can see respiratory components or cardiac components that if your sampling rate is really fast, you actually can distinguish in the spectrum. The problem is that the TR, or most of the time our TR up to now, because we have like multi-band sequences that can allow us to accelerate the acquisition, our TRs were about 2 seconds. So all these components are aliased and moved to the low frequency range that where the ball response occurs. So we cannot actually distinguish them. So that was for task-based fMRI when you specify one regressor. In resting state fMRI, the reference signal is usually the time series of a voxel of a region of interest, and then you compute the correlation or use that signal as your ideal model to fit your data. The issue here is that any kind of confound or signal that could be present in a voxel could actually create a spurious correlation that then you interpret as a connectivity to that particular voxel. So which kind of components or which components are in the fMRI signal? So probably the most important one is the one related to motion. So when we collect the images, of course our subjects are moving the head. So actually, sorry. oops. So, yep. So, well, if that motion is correlated with the timing of the task, or you can introduce signal changes in the signal that could create spurious correlations between boxes. And this is not seen in the images that we collect, but if we get and see the signal percentage, then these the signal changes due to motion are very clear, especially in the edges of the brain. So another component of the fMRI signal is due to cardiac pulsability that generates small movements in brain tissue as well as inflow effects in around vessels. So it's mainly localized close to the large arteries and the draining veins and the edges of the brain and the lateral verticals. If you sample really, really fast, as you can see here in the video, and we focus on a point where we have a vein, we actually can see the movement of the voxels and the change in the intensity of the signal due to this cardiac pulsability. Our heart rate is about 50 to 70 beats per minute. So the main frequency of the cardiac component is between 0.8 and 1.2 hertz, depending on how many beats you have per minute. And if you look at the power spectrum, you can really see the peaks of the cardiac noise around, in this case, 0.8 seconds. And if your sample rate is really, really fast, you can even see the second harmonic of the cardiac pulse. And most of the, as I said, the effects of the cardiac noise are mainly localized in the nearby the large arteries and the draining veins. Then another component of the signal is respiratory noise. So thoracic movements during breathing result in respiratory dependent changes in the magnetic field in the head volume that produce a phase shift in the image. So the effects of respirations in the signal are more global than the cardiac pulsability. The breathing rate is around 15 to 25 cycles per minute. So the main frequency of the respiratory component is between 0.25 and 0.4 hertz. And you can see that in the power spectrum of this particular voxel. So importantly, as you can see in the figures on the left, this is independent of the head movement. So in this experiment, what they did is they attached 2 bottles of copper sulfate to the head coil, but not to the head. And they asked the subject to do a breath hold, so there are no fluctuations in respiration, and they measure the time series that you see there are the time series not in the brain, but actually in the voxel. And you see that there are no fluctuations during the breath holding period. As soon as they instruct the subject to breathe normally, these changes in the phase of the signal create oscillations in the time series that, of course, then later if they ask the subject to do another breath hold, then those fluctuations, those periodic fluctuations disappear. Then apart from these high frequency cardiac and respiratory fluctuations, we have low frequency physiological fluctuations that occur below 0.1 hertz. Like, for instance, variations in the respiratory rate affect the fMRI signal by changing the oxygenation level and the arterial level of CO2, which is a potent cerebral vasodilator. So in this very clear sample by Richard Weiss and colleagues, what you see is that changes in the tidal CO2 they actually can explain a lot of variability in the signal that can be seen in the gray matter and the white matter in the matter voxels. Another source of the fMRI signal is the effect of draining veins and large arteries. So usually in fMRI, what we employ is gradient echoplanar images in order to acquire our our data. But those images have a very strong contribution from micropulses that are mainly localized in the piral surface. So this ball contamination from the macropulses are a serious impediment for high-resolution localization of neuronal activity in fMRI. In order to overcome this effect, you could use spin echo images, but then the sensitivity to the ball effect, especially at low high fields, like are not to at magnetic fields lower than 70, is the sensitivity to the ball effect is substantially reduced. Then another source of the fMRI signal are very, very low frequency drifts that occur to very slow head motion or scanner-related drift, for instance, due to the warming up of the amplifiers during the acquisition. And you can see that different boxes have different low frequency trends. Then you could also have hardware-related instability. Nowadays, most MRI scanners use multi-channel receiver coils for data acquisition. And then the signal from the different channels is combined in order to get our time series. But what if two channels are faulty or have a problem? Then what it creates is it creates very localized artifacts in our data that only occur in some areas of the brain. So for instance, in this image here is a voxel on the voxel on the right. You cannot see artifacts in the middle of the acquisition, whereas the boxes in the left part, in the left frontal part of the brain, they have artifacts during at the middle of the acquisition that are due to the malfunction of the multi-channel head coil, and that can actually create a very strong and a very strong artifact that then, if you want to get, for instance, functional connectivity maps from these areas, what you will see is basically the correlation map due to the artifact. So this is a very serious confound that you have to account. And I would encourage you to go and attend the talk by Daniel in order to optimize the data acquisition and to perform quality assurance on your data and during your acquisition in order to avoid these problems. So now that we have gone through all the most common sources of the fMRI signal, I'm going to describe methods for denoising the ball fMRI signal. And probably the most common one is, in order, I will start with to try to compensate for motion-related effects. And the most common practice is to do volumetric realignment, when we try to correct for displacements in the three directions, X, Y, and Z, and also in rotation. When we rotate, we register each of the volumes to a reference volume that we don't that we use as a reference. So as a result, we have we can more or less correct for those motion effects, and we have time series for the translation and the rotation parameters. But it's important to realize that realignment doesn't fully compensate for motion-related signal changes, and it cannot correct the data as if motion had never occurred. So for instance, with this approach and like the realignment parameters, you will not be able to see slice-wise motion effects that occur during within volume acquisitions. And for that, you have to use more sophisticated approaches like a slow MoCo, or for instance, using the EEG cap as a motion sensor that can actually account for these slice-wise motion effects. Also, you can use prospective motion correction, for instance, using navigators and optical tracking systems. Then the next thing that is very popular is try to use those realignment parameters as nuisance regressors in your model. You could incorporate the realignment parameters that you will have 6 regressors or their temporal derivatives to just to account for shifts in the signal, or the corresponding squares of those regressors, that you will have 24 regressors. And even if you are really concerned about the effect of motion, you can increase to 36 regressors, that you use the second temporal derivative. So 2 time shifts of the realignment parameters and their squares. The problem is that the more nuisance regressors that you use, the more loss of degrees of freedom and the less statistical confidence that you have. So what you can see basically is like, as you increase the number of regressors, you can remove this banding effects in the signal that you can see here in the gray plots. In the gray plots. So in this session, I will encourage you to go to Jonathan Power's talk to know how to create these beautiful gray plots that are really useful, and Molly Bright's talk to know more about the critical questions for performing nuisance regression. Okay, but you have used the motion, the realignment parameters to try to remove motion-related effects, but there is still sometimes that there are extreme cases where large head movements that they cannot be explained. So one approach could be to censor those time points. So you have to first identify those time points and then exclude them from further analysis, or try to interpolate with new data between the closest clean time points. In order to identify those time points, you can use metrics like based on the realignment parameters, like frame-wise displacement, or D-bars that are based on intrinsically in the fMRI signal. You compute, it's based on the derivative of the fMRI signal, or you could actually compute like the percentage of boxes with a spike-like pattern in each time point, for instance, with 3D spike in AFNI. Then you use those time series in order to identify which time points you want to censor. But it is very important to report in the methods of your paper which criteria and threshold you have used for censoring, and which definition, for instance, of frame-wise displacement you have used, because there are multiple ones. So just using one threshold and it's not enough. You have to actually define the definition of the papers, because different definitions of of frame-wise displacement have different slopes. So the value of the threshold is dependent on the definition and what you have done. Another algorithm in order to correct for motion could be to actually compute the principal components of a data set that simulates motion. So in this approach, what they do is they take just one volume, and based on the realignment parameters, the authors propose to rotate and translate that single scan according to the motion that it has been estimated. Then, of course, you don't have neuronal activity in that new and motion simulated data set, and then you compute the principal components of that data set that you can incorporate in your model as nuisance regressors, or you could actually apply the realignment on that data set and compute the principal components of both of them, of both data sets. And it turns out that it explains more variability related to motion than using the realignment parameters. Another possibility could be to use the principal components based on the box cells, on the principal components of the box cells that are in the edges of the brain. In that case, it's very important to realize that there are some areas with signal dropouts, so the the mask for the 8 brain voxels should be the intersection between the functional and the anatomical image. But those previous methods try to explain motion-related effects. But if you, there are other methods that try to account for motion-related effects and other types of noise or physiological noise. So for instance, in this approach, phase-shift soft tissue regression, what they do and propose is compute the average time series of white matter arised, the CSF from the lateral ventricles or from soft tissues like the face, the skull, and then, of course, get the realignment parameters, and then cross-correlate each of these time series with the average signal of the brain or of the gray matter, and then compute the optimal lags for each of the regression, and then incorporate this lag time series into the model as Nuisance regressors. Or you could use, another method is ComCore, where the principal components are computed from the voxels within eroded white matter and CSF from the lateral ventricles. This is no anatomical ComCore, or from voxels with the largest temporal standard deviation, or a combination of both. Importantly, these approaches can actually model not only motion-related effects, but also physiological fluctuations, like, for instance, respiration and cardiac. The important question in all these methods based on principal component analysis is that determining the optimal number of principal components is an open question, so it is not known whether you should use a fixed number or depending on the percentage of the explained variance. But these approaches try to use the average of the white matter signal, the average of the signal in the CSF in the lateral ventricles. But if you have very localized effects, you should use a more local regression approach. So for instance, in Anaticor, what is proposed is that you compute the average signal over the white matter voxels inside a radius, inside a sphere surrounding a sphere center in the gray matter voxels, and then use that as a voxel-dependent Nuisance regressor for each voxel. Then with that, what you can do is actually remove these localized hardware instabilities, and as you can see in this map, is you can retrieve the underlying pattern of functional connectivity from those voxels that were in the areas affected affected by the malfunction of the channel coil. Another approach would be to use independent component analysis. So if you want to use ICA for the noising, you use your favorite ICA algorithm. In ICA, what you do is you decompose the data into independent spatial maps, and each of them has an associated time series. Then you compute spatial features from those independent component maps, or temporal features from the time courses for each independent component, and then you try to classify each component either in signal or in noise-related artifact. For that, it's very useful to use some ICA viewer like MailView, and basically what you do is like looking at the spatial map, or looking at the frequency of the time course, or the time series of the time course, is you decide whether it is a signal component or is an artifact component, like in this case is movement. But in some cases, it is extremely difficult to distinguish whether it's a ball-related component or a noise component. Then, based on that classification, you incorporate the time courses as nuisance regressors in your model. In a non-aggressive manner, you will include all of them, like the signal and also the artifact, the time series of the signal and the artifact components. Or in an aggressive approach, you will only include the time courses related to the noise components, and then you remove the part of the signal explained by this noise, by the time courses of the noise components. Essentially, in order to do the classification, you can do a manual labeling. So is the gold standard only and only if it is done by experts. It's time consuming, it's difficult to reproduce, but still it is very, very useful and it's recommended. And there are some guidelines in order to do the manual classification. And there are multiple methods for the automated and semi-automated classification that they differ in the algorithm, the spatial features or the temporal features that they use. Then, but those methods are based on the fMRI signal itself. But it turns out that most of our scanners have physiological monitoring units, so that allow us to record traces related to the cardiac pulse or the respiration of the subject during the acquisition. So for the cardiac pulse, you can record the pulse oximeter signal or the ECG signal, and for the respiration signal, you put a pneumatic belt around the abdomen or the thorax of the subject. And then you can use that information in order to remove these physiological noise components of the signal. So probably the most popular approach is retroicor, where you basically compute the phase of the cardiac pulse and the respiration with respect to the timing of acquisition of each slice. Then, based on that, you can compute an instantaneous, a time-varying phase or instantaneous frequency that fluctuates in time, and then you develop. It's possible to develop a Fourier model that uses those instantaneous frequencies in order to create nuisance regressors that can account for the respiration and the cardiac rate. The beauty of this approach is that it can actually remove physiological noise fluctuations that are aliased with the Bolt signal. Then you can also use these physiological traces to remove low frequency fluctuations in the respiratory volume. So, for instance, variations in respiratory rate can be reduced by regressing out changes in the respiratory volume time series that are assumed to correlate with fluctuations in the arterial CO2 concentrations. So, for instance, in regular breathing, if we look to the envelope of the respiratory signal, we see that it has a very low frequency response, that it doesn't overlap with the main frequency of the respiration. You can see in the red spectrum, and that actually correlates very strongly with the fluctuation, or could correlate very strongly with the fluctuations of the fMRI signal. If you ask the subject to have a constant breathing, then you see that those low frequency fluctuations more or less disappear. But you don't know whether the subject has a regular breathing or a constant breathing. And what you do with this, so once you have estimated the envelope of the respiration, then you compute the correlation with the average signal in the brain and multiple lags. And then you identify the two lags that have the maximum positive and negative correlation, and then you can add those two lags in your model as noise and regressions in order to explain some variability of your data. You can actually do a very similar approach for the cardiac rate, so you can you can compute fluctuations in the timing between two successive cardiac pulses, then again have a time series of those changes in the cardiac rate, then you correlate with the average signal of the brain, and then identify the two lags that have the maximum correlation, and then incorporate that into the model in order to explain some variability. But you can use 2 lags, you can use 4 lags, 12 lags, like how many? And you're increasing the degrees of freedom to model your data. So Rasmus Bern and Katie Chan had a very clever idea that it was to identify the respiratory response function and the cardiac response function, that are the response of the brain to the respiratory volume time series and the cardiac rate time series. So actually you can convolve this respiratory volume time series with the respiration response function and the cardiac rate time series with the cardiac response functions in order to account for more variability in your data by just using two regressors. You can extend that approach if you actually want to model end-tidal CO2 fluctuations. So and you can more or less do the same procedure in order to estimate the response function from the end-tidal CO2 changes, or the cardiac rate, or the respiratory function. It's important to notice that the cardiac response function and the respiratory response functions could vary across subjects. So in some occasions, and mainly in clinical cases, it might be particularly useful to estimate those functions at the single subject, so for each individual subject. And also, if you have the opportunity, you can actually measure changes in the blood pressure with an MR-compatible continuous blood pressure device in order to minimize intrinsic fluctuations related to cerebral autoregulation. And it turns out that the continuous blood pressure traces have been observed to strongly correlate with the global signal. So it seems that changes in blood pressure account for a lot of variability in the data. Our standard acquisition is based on single echo fMRI, where the signal is only acquired at that echo time that is assumed to be optimal when it's equal to the T2 star parameter of our voxel. Yeah, but what you can actually do is to collect more echoes during your acquisition, because the T2 star parameter is variable across voxels. So you can, at different echo times, you can recover intensity in some areas that are susceptible for geometric distortions and are close to air and tissue interfaces. Then you have three volumes with different volt sensitivity that you can actually use in order to improve your signal. This doesn't have any cost in terms of energy deposition, since there are no additional excitation pulses. It has a slight increase in the TR of the acquisition because you have to acquire multiple echoes, and a slight decrease in spatial resolution. But this is not really a problem nowadays because we have simultaneous multi-slice acquisitions. So what you can do with these multiple echoes is try to combine them in order to recover signal in regions with large signal dropouts and standard single that in single echo acquisitions, like for instance the inferior temporal the temporal pole or the orbitofrontal cortex. And you can see in these temporal SNR maps that the signal is improved in these areas compared to a single echo acquisition. But in terms of the noising, what you can do is if you have a dual echo approach where you record just 2 echoes, then you can acquire a very, very short signal, a very short echo time, and that signal will be mainly weighted and will be susceptible to changes in the neck magnetization that is capturing motion-related effects, inflow effects, and respiratory-related fluctuations. And then actually use that signal in a voxel-dependent manner as a nuisance regressor to denoise the signal acquired at the optimal T2 star. And you can actually remove motion-related effects from your activation maps or correctivity maps. Then if you collect more than 2 echoes, you could do approaches like multi-echo ICA that I'm going to skip for the sake of time, and I will encourage you to go to attend Prantik Kundu's talk on this session for more ordination with multi-echo fMRI. And then a very interesting application will be if you have a non-constant TR with multi-echo fMRI, you can remove those strong T1-related fluctuation effects that appear when you don't have a non-constant repetition time. And this can be effectively removed by dual echo, multi-echo ICA approaches, as you can see in this figure. Finally, the phase-based methods. So in MRI, so the MRI is inherently a complex signal. So it has a real part and an imaginary part. Typically, we only look to the magnitude of the signal, but the phase contains relevant information about magnetic field variation and differences in susceptibility in regions near air and tissue boundaries. But we usually neglect that information. But in terms of denoising, it can help us to remove the effect of large vessels and draining veins in gradient echo fMRI. So if you want to do high resolution fMRI and you want to go to the site where the activation occurs, that is in the capillary bed. So the quasi-random orientation of the vessels in the capillary bed results in incoherent phase signal changes. So if you are in a voxel when you don't have veins or large arteries, the signal change to an stimulus, it will be seen in the magnitude of the signal, that is what we usually collect, but the phase signal will be independent of those task-related change of this task. But whereas when you are in a vein, those task-related signal changes can be observed both in the magnitude time series and also in the phase time series. So what you can do is to actually fit that phase signal to the magnitude signal and then actually remove the effect of the large arteries. And this can be seen only in those voxels where we have veins. And here you see a beautiful map of where the phase signal can explain a lot of variability of the magnitude signal across the brain. So as a conclusion, we can say that fMRI is extremely noisy. I think we all agree with that. That's why you are all here. The Ball effect due to neuronal activity is only 2 to 5% of the mean amplitude, and the signal is corrected by multiple noise time series. So denoising is critical for both task and resting state fMRI. There are multiple techniques, like many of them, for denoising the bold fMRIs. Most of them concentrate on denoising motion-related effects and physiological noise effects. But you can actually improve the denoising, but adapting a little bit your acquisition and, for instance, recording the phase of the signal or using multi-echo fMRI. But it's very important to realize also that there is no best method for pre-processing or for denoising. And it's very important to do things in the right way. That's why you will see like the experts explaining you how to do this, how to implement these approaches, because it's very easy to apply them in an incorrect manner. So if you want, as a final advice, is always look at the data before and after pre-processing. So you actually see whether you have artifacts in your data after all the pre-processing. I will encourage you to read the special issue, but for this presentation, everything that I have explained and much more is reviewed in this paper. So thank you very much for your attention.